Welcome, and thank you everyone for joining us tonight for our update on COVID-19. I'm Susan Solomon, the CEO and founder of the NYSCF Research Institute, and this evening we welcome back two extraordinary panelists and experts in the field, Dr. Wafaa El-Sadr and Dr. Siddhartha Mukherjee, to discuss ending the pandemic here in the US and around the world. As I'm sure you know, Sid is a hematologist, an oncologist, a Pulitzer Prize winning author, and a NYSCF board member. Wafaa is an epidemiologist, a world-renowned global health expert, and a MacArthur Fellow. They're both educators at Columbia University, and Wafaa directs the Global Health Initiative at the Mailman School of Public Health. Sid and Wafaa, we are thrilled to have you both back with us today, and I am very, very excited to have this conversation about how we can change the trajectory of the pandemic around the world and finally end this scourge. Before we dive in, I want to acknowledge the support and transformative partnership of the Stavros Niarchos Foundation, which has made events like today's talk possible. Currently, we have a matching grant challenge. If anyone is interested in supporting our educational content, that would be wonderful. We encourage everyone to submit questions via the chat function. Just as a note, we cannot answer any personal medical questions. So to the topic of today's discussion, it's not a simple question. The end of the pandemic requires an understanding of what's going on around the world. One of the current big stories that scientists are currently studying is the new variant that was first identified in India and has had a devastating impact on the country, or the Delta variant, which is now apparently the most common variant found in places outside India, like the UK, and is also on the rise in the US, which means that it's outcompeting the Alpha variant, which was first identified in the UK, that at the time was seen as the most transmissible variant. And I'm sure everyone is wondering about that, about the effectiveness of the vaccines, how well do they protect against infection and hospitalization. And I thought perhaps we could discuss this first because the impact is so huge.
Absolutely. Where do you want to start, Susan? Would you like me to start? Would you like Wafaa to start? Tell me how would you like to?
Sid, why don't you start on the whole question of the Delta variant, and then perhaps Wafaa, we could talk about the role of the world, our connected world, in bringing this pandemic to an end. You know, we have the Tribeca Film Festival last night and 100,000 people gathering together, and people ripping off their masks, you know, in New York. But we have a very, very different situation just a few hours away by plane.
So let me talk a little bit about the variants. As you know, the two variants of the greatest concern, actually there were three variants of great concern, which have now been relabeled. One was called P1, originally identified in places like South Africa and a couple of South American countries. The second one is the so-called B117 variant that has been now relabeled, and now is the B1617 variant. That is the one that was first identified in India, but of course has now spread across many parts of the world. So it's no longer the word Indian variant or Kent variant or Brazilian, South African, those don't even make any sense.
Right.
All viruses have mutations, obviously. These variants have particular mutations in the spike protein, the protein that the virus, that the SARS-CoV-2 uses to attach itself to the human, its human receptor. But more importantly, it seems that there are two characteristics of these variants which make them especially variants of concern. Characteristic number one is that their transmissibility seems to be higher than the wild type. So they are more transmissible than the wild type variants. Factor two is their pathogenicity, which is related to their immune escape, also seems to be higher. And of course, once you have those two things combined, you get faster disease, more people infected, and you get more people more severely ill from the infection. And we can talk about, without going into the weeds, about some of the causes of this. In fact, B117 and B1617, the two variants of concern, have things that they share in common. But again, we can talk about that. But really now the biggest concern is B1617, the so-called Indian variant, although as I said, it's now spread over many parts of the world. So that variant has increased transmissibility and increased immune escape and increased pathogenicity. The question that's really on everyone, it has devastated India. It is now moving into Bangladesh and Pakistan and Thailand and other places which seem to be safe for reasons that we really didn't understand. It is now moving into some of these places very quickly. It has certainly moved into, as you very well know, Northern England has been, the cases have risen hundreds of percentages in Northern England, and there is plenty of evidence that it's in parts of the United States, including the southern United States. The question that's on everyone's mind is, how bad is it? And more importantly, how well do the various vaccines protect against it? And you'll be surprised or shocked to know that although there's a lot of laboratory data, so in other words, you can ask this question in many different ways, right? You can ask the question, one way you can ask the question is, how many people who have completed 2 full doses of or 1 dose in the case of Johnson & Johnson, or 2 full doses of Moderna, Pfizer, or AstraZeneca, right? So those are the 4 vaccines that we're really talking about. We can talk about some other vaccines later. The one question you can ask is how many people who've completed those full doses and have gone past the period of time after the second dose, when you would expect them to be 80 or 90% immune to the virus, as was the case with the original wild type variant. That was the Pfizer study, similar to the Moderna study, pretty similar to the Johnson & Johnson study, and with a little bit less effectiveness, the AstraZeneca study, right? The question you want to ask, one question you might want to ask is how many people who've completed both of those and have acquired the immunity that they're supposed to have acquired can become reinfected with the 1617 variant. And number 2, if they become reinfected, do they get less sick, just as sick, or more sick potentially than a comparison group, someone who wasn't vaccinated. Now, the astonishing thing is that we don't have the answer to that question, and that's partly because it's an incredibly difficult question to ask in India, because we didn't have enough vaccine available. So the denominator, so by the time the virus was spreading like wildfire in India, the population of people who had completed both doses of vaccination was on the order of 1% to 3%, right? So even though you have 1.3 billion people, only 1 to 3% had completed the vaccination. Many of them acquired 1617 in the middle of their 2 vaccinations. so they had to be excluded. Some of them acquired it before they got their first vaccine, so they had to be excluded. And so the astonishing thing is that even today, I'm now talking about the AstraZeneca vaccine, Pfizer and Moderna were not present in India at that time. Even today, I mean, I've been corresponding very regularly with various people who are in India, including people at the Indian Council for Medical Research. Even today, we do not know the answer to that question. In other words, if you completed 2 doses of AstraZeneca and you were well out of the window when you were supposed to have generated antiviral immunity, what are the chances that you get infected or reinfected with B1617, and how severe is your disease? The only thing we know is a small study published in bioRxiv, the open channel network, which followed some healthcare workers and tried to do a good job in terms of figuring out if they were in fact fully immunized or fully vaccinated, how many of them succumbed then to infection with B1617, and how bad was the infection. And the answer seems to be not dispiriting, but it's on the order of 70%. There's no comparison group, but 70% of those people, these were healthcare workers, so they were highly exposed. 70% of those people did, in fact, get protected. They did not have, until the time the study finished, they did not have B1617. 30% of the people approximately got B1617, but their disease was mild. These are younger people because they're healthcare workers. Their disease was relatively mild, and I think there were no deaths, if I remember correctly. Okay, so, and this is from the AstraZeneca vaccine. Now, coming back to Pfizer and Moderna, we have a large amount of in vitro studies, in data studies, laboratory studies, that would suggest that the antibody response, if you're getting an antibody response, neutralizes 1617 in laboratory assays. And the neutralization capacity is very high. And there is one study, again, small, that suggests that the effectiveness of Pfizer and Moderna, Pfizer in this case, is on the order of 80% or higher in protecting you from 1617. So that's very encouraging news. It's very positive news. But so that is the extent of the news that we have. Now, you could ask a second question, which is, what is the chance that you will acquire what is the chance that if you're in the United States and you are not vaccinated, that you will acquire 1617? And as you were saying, that is a dynamic or moving target, because initially, most of the world had the wild type strain. Then it moved to the 117, which outcompeted the wild type strain where it arrived. And now it seems like 1617 is now outcompeting even the 117 strain. So chances are that if you are not vaccinated, either with Pfizer and Moderna, or maybe Johnson, we know the least about that, either with Pfizer and Moderna, chances are that you will indeed contract 1617, and it causes an unpleasant disease, very unpleasant disease. So much so that we have seen, which we hadn't seen with 117, and we had not seen with the wild type strain, we're seeing children dying. Yes. Children in India, I know, I can tell you several children and adolescents dying from 1617 COVID. So what's the moral of the story? It's just the same moral that we had before. Get vaccinated and continue to take precautions, because it ain't over. We are in the end, and everyone's rejoicing on the streets. If you're vaccinated, I think you have a little bit more reason to rejoice. We've had one full year, which has been nothing but terrible. But I don't think that we can let our guards down now, and that's important. I'm going to make one last point, and I'll let Wafaa continue on the global front. My one last point is, there's a huge interest in figuring out whether the virus has finished its tricks, or are there more tricks up its sleeve? And if you ask virologists, and I've been speaking with them, if you ask virologists like Michelle Nussenzweig or others, several across the world, some people believe that there are no further tricks that are of great concern. I mean, the virus will keep mutating, there'll be more mutations. But after a certain point of time, you cannot accommodate more mutations because it bends the protein in a way that it can no longer bind back to the human receptor. So that is also, I mean, I suppose it's mixed news. It's already done its two nasty tricks. And so again, we come back to the same point, which is to say, it ain't over, get vaccinated, and try to get the world vaccinated, because every flight that comes from any place is bringing in 1617 as well as 117 as well as the wild type variant. And 1617, if you're not vaccinated, I can guarantee you is a deadly disease. So I'll stop here and let Wafaa continue.
I want to interject one thing, which is your point, and Wafaa, perhaps you could pick up on this. I'll just give you an anecdote. I was fortunate enough to just be in California at a live graduation, my grandson's high school graduation, and they had been at Zoom school, and all the kids were very depressed. And the last few weeks, they were able to go to school. They had prom, and they had a live graduation. Everybody very separated, everybody masked. But the kids were together and processing, and it was quite a joyous thing. And afterwards, there were a series of parties and so forth, and a lot of talk about travel, lots and lots, this particular group, a lot of international travel and kids going everywhere in families. And I was struck by, and all of the kids had been vaccinated at this particular school. I was really struck by, what does that mean to take care? I've gotten so used to being, everywhere in a mask, as a cancer survivor, I, rightly or wrongly, I feel it's more appropriate for me to be masked, but to have people now, kind of hugging and shaking hands and taking off masks. And of course, we have all of the children who are under 12 years old who don't right now have the possibility of being immunized. So when we say take care, my instinct is that we really should still, that it's too soon to take off the masks and give big hugs to wide groups of people and so forth, but I seem to be in the minority.
Yeah, hi, thank you very much. And thanks for the opportunity again to speak to all of you. And I'll build on what Sid mentioned. I do think, when I think about it, I think we're very fortunate, particularly in this country, to have some fantastic vaccine options. And that's really important to keep reminding everyone of the availability of vaccines and the really the urgent need for individuals to seek getting vaccinated as soon as possible. I always say that thus far, our biggest shield against the virus has been the mask, the face covering, and now our biggest shield against the COVID-19 should be the vaccine. And that's why we need to hopefully achieve a much higher coverage of vaccination in around the world and in this country. I think it's interesting when in New York City, in the United States overall, we did have a bumpy road early on in the vaccination, but then we're briskly achieving large numbers of vaccinations per day. This has really stalled over the past several weeks, which is of concern. So the numbers of people who are getting vaccinated on a daily basis has been decreasing. And I think it motivates all of us to keep really trying to very much motivate people, listen to people and their concerns, and try to address their concerns and use trusted messengers and so on to be able to get more and more people vaccinated, because that's ultimately really what's going to protect us, not just us, but the world as a population. So I think what we're seeing now, and this gets to what Sid was saying, is that it seems like the world is getting divided into the haves and the have-nots, the people who have access to vaccines and those who don't have access to vaccines. And that's another disparity. I mean, in the US, we are certainly seeing areas of the country where vaccine coverage is quite low, alarmingly low. And there are various reasons for this, and we don't have to get into them, but this is of concern. So there are disparities within countries, but also disparities across countries. And I think the situation of India is very instructive in that this new variant essentially attacked a virgin land. It was a population that had hardly been touched with vaccines at all, and you see the consequences were horrific. So the urgency of getting vaccine coverage is very important, and I think it's and getting to your question, Susan, is that I do think that I still recommend that in situations where you really don't know the vaccine status of the people around you, is that it behooves people, whether they're vaccinated or not, to still continue to wear a mask, because you don't know the vaccine status of, if you're in a situation where you don't know the status, and that's very hard to know the status, vaccination status of everybody in these contexts like you described, then it behooves people to continue to mask in those situations. Now, in terms of what's coming next, I think in many ways, I don't think most epidemiologists or infectious disease experts like myself or virologists or others believe that we're going to kind of come to one day and say it's the end of COVID-19. Because of this disparity that we have in terms of access to vaccination, we're going to continue, unfortunately, to have contexts where the virus will continue to simmer with occasional surges because of the lack of vaccination and new variants and so on. And that means that what we need to do is, as much as possible, get coverage with vaccination, but also work very hard to get get vaccines to as many people around the world as possible. I always say COVID anywhere is COVID everywhere. And this is the way it is with any virus. And the good news is that even with these new variants, what we've seen based on population studies is like, for example, some excellent studies that were done in Qatar at a population level. It showed that this population that had been vaccinated largely by the Pfizer vaccine, but I'm sure it would be similar with other similar vaccines, that the vaccines were quite protective against the initial B117, which is the UK variant, Alpha now variant, and also against the South Africa, the one identified first in South Africa. So that's good news. And then the other piece of good news is that in the UK, even though they've seen an increasing number with the 617, the Delta variant, which is the one that first identified in India, is even though there's been an increase in numbers of cases in the UK with this variant, there hasn't been an increase in deaths. Which tells me that, again, at least I haven't seen it in the data that I've had a chance to look at, it tells me that the vaccines, which ultimately we want, are the vaccines that are protecting against severe illness and death. So the goal should be for people to get vaccinated as soon as possible, as well as also our global responsibility to get vaccines to as many people around the world as possible to get vaccinated.
I'm sure that you were both dismayed to read about the sort of continuing follow-ups that has led to millions of Johnson & Johnson doses, expiring at the end of the month and so forth. And there are reasons why, and the pause and so forth. And I read today that it seems logistically impossible to get those vaccines, out of the country in time. I can't imagine why that is, but it seems as though we don't know if the Johnson & Johnson is going to have the same efficacy as the mRNA vaccines, but it certainly is a reasonably good vaccine. How do you think that we will be able to tackle this question of inequality? I know we've committed to, I think it's, I don't remember the exact amount that the president has committed to. I think it's 500 million doses.
500 million, yes. Mm-hmm.
Doses. And I don't know if that included or didn't include the soon to expire doses. But how do we actually make sure that we get the vaccines to the communities and the countries that need them, but then that we actually get the people to accept them. I mean, I've had, and I'm sure you've had, just endless conversations with people ranging from my body is my temple and I don't want foreign substances in it to, you know, every possible thing. And at NYSCF, we've made it mandatory to be vaccinated, to be on premises. If you want to be on premises, to visit, to come and repair something, or to work, you must be vaccinated.
Yeah, and Columbia University has also mandated as well vaccination for students, faculty, and staff, with of course the option for people who have legitimate medical or religious reasons. They submit a request for consideration for exemption, but those are the only exemptions that will be offered. I mean, I think, you know, there are people, it's a big spectrum of people within the people who haven't been vaccinated. I think there are some who are more in the wait and see. I want more information. I want to be sure or it's complicated. I can't do it. I'm too busy. You know, all of these kinds of issues. And I find that engaging with such individuals can sometimes be very helpful. And I think some of the efforts now to make vaccines, to bring vaccines to the people rather than expecting people to come to the vaccines are also really good, like mobile units and putting vaccination to subway stations and in ballparks and beaches and is really the way to go, as well as to bring it to homebound individuals, as well as to also reassure. I mean, I think the more people see others like themselves who have gotten vaccinated and are doing fine, I think I found that several people have told me, well, I started looking around me and a lot of people got vaccinated and they're doing just fine. So that also encourages people. So I'm hoping that over time we'll be able to get the people who are sort of on the fence in terms of wanting to get vaccinated to get them hopefully convinced to get vaccinated as they watch others around them.
Well, you had made the point when we were speaking together at the end of January, how important it was to actually bring the vaccines to people, as opposed to, you know, we have these mass centers, some of which, you know, have been shut down,
Yes.
to actually bring the vaccines to where people are and to people who, and have it offered and set examples by people who are trusted by the community.
Right, right, and that is helpful. I think we can't sort of ease on the efforts. I think that's the important thing. Like I said, New York City now, we have about a third of adults in New York City. Even though we tout how well New York City is doing, about a third of adults in New York City have not even received one dose of the vaccine.
Right.
So, I mean, we tend to look at the opposite. We look at 70% have received at least, you know, or 60-something percent have received at least one dose. But we need to think about actually the opposite, how many have not yet received even one dose. And I think that's worrisome, but I think it's these are the numbers we need to keep an eye on all the time to see how we get. And we have evidence that it works. I mean, we can see the mortality going down, especially amongst older individuals who are more obviously susceptible. And we see a decrease in numbers of cases, and now fantastic data are coming out in terms of from countries like Israel, for example, where they saw with increasing vaccination that the numbers of cases in young people, the under 16 years of age, is going down. So by vaccinating more and more people, you're protecting the unvaccinated as well. I think
and then be an excuse for, you know, for the free rider syndrome, right? For people who say, well, I'm going to just rely on everybody else being vaccinated, but, you know, it doesn't.
You remain susceptible, of course, and you remain vulnerable to a surge and, you know, these surges that can happen anytime. So anyway, I think the efforts need to continue, and we need to be able to address all of the concerns as they arise. People ask questions about the variants. People ask questions about, I've already had, one of the common questions I hear, common refrains I hear is, I've had COVID already, so I'm fine. And we actually think that there are data that show that even people who've had COVID have recovered from COVID. If they get vaccinated, their antibodies, their immune system responds much better and they have much better antibody levels and cells that are activated against this virus. And that's the reason why even people who've had COVID, they should get vaccinated to get to be additionally protected. So, but those are the questions, and I think engaging with people and trying to answer them is the way to go forward. There will be some, but it's a small group. There will be some who are the ones who are against all vaccines, for example. It's very hard to convince them of this. But we can do our best to get the people who are, again, contemplating what to do. We can get them to be ready to get vaccinated.
Yeah, I think it's, I know that pediatricians and public health folks are very concerned about a measles surge because so many children have missed their regular immunizations. What do you think, how much do we know about really two things? First, whether vaccinated individuals, asymptomatic vaccinated individuals, if you contract COVID, can you pass it along? And second, how will we know when it's time to get those boosters that we hear about? We don't yet have a commercial test, as far as I understand, to determine when your immunity is waning. There's no, kind of alarm that goes off, time to go get another vaccine.
So a couple of thoughts about that, Susan. I think that, let's say the answer is in reverse order. So the vaccination schedule for COVID is among the most aggressive vaccination schedules for vaccines, period. So compare it, for instance, with the childhood vaccines, MMR, or others. You don't get a booster shot in 21 days. It was the only one that's even comparable is the Shingrix, right, the vaccine for varicella, where you have a rapid booster. Now, sorry about that. The important piece of this is that we need to, sorry, let me just email there's no way to silence that door, so I have to email my daughter to open it. Pardon me.
I think that's one of the nice things, the few nice things about the pandemic is that we all saw each other in a context, not just as a professional in a box, but with the cats, with the children, with.
Yeah. So here are the so I think based on the good news is the Pfizer, and if you get a good antibody response against the Pfizer and the Moderna vaccines, we haven't seen that antibody response wane quickly. It seems to last for a while, and it seems to stay for a while. Buzzer. And so it seems to last for a while and stay for a while. But however, as you know, they were designed against the wild type variant and not against 1617. And so I suspect that we are going to have to get a booster. And my suspicion is probably the winter, in the winter months. So that's one question. Now, there will be a struggle, and there will continue to be a struggle within the FDA, so for an mRNA vaccine or even for an AstraZeneca vaccine, whatever the vaccine is, it is certainly possible to make a quick change, and incorporate the mutations that these new variants have. The question is, do we have to put that through a full trial? And there are people like me, at least, who believe that those changes are not necessary. That a full new trial is not necessary. That the new booster can have an EUA status, an emergency use status, and that the most vulnerable people will get it first. Obviously, the elderly, people who are in hospitals, or people who are in long-term nursing facilities, and we will watch and then convert that EUA into a full vaccine authorization. That's what I believe should happen. But there are others who would argue that you have to go through a full trial first. I'm afraid it's going to become very hard to do a trial with the Pfizer and the Moderna vaccine with the variant changes, because the numbers are dropping dramatically in the United States, And in places that they're not dropping, they don't have that, they don't have Pfizer or Moderna. So, and they don't even have Johnson & Johnson. So it's a somewhat circular problem, but I suspect the answer is in December, we will probably get a booster. Now, your last question, what evidence do we have about transmission if you're vaccinated? There's very good data from Israel, observational, but very good, very strong data that Wafaa was talking about, in where you saw that as the vaccinations increased, the curve of infections, new infections among unvaccinated people decreased. And this was a very clear phenomenon. It was very clearly observed. And it strongly suggests that once you get vaccinated, you don't only protect yourself, you potentially protect other people. Now, there's a good news and bad news in that. The bad news is that there will be free riders, right, who will say, oh, everyone else can get protected, but I will, keep my course. The good news in that is that we still don't know when and how to vaccinate 12-year-old and youngers, and
Right.
certainly B1617 or the Delta variant can cause disease, and quite severe disease, in unvaccinated 12-year-olds and younger. We've seen several case reports. Now, obviously, the disease gets worse and worse once you get older, but don't for a second think that if you're 12 and under, that you're getting a free ride, because 1617 can cause pretty severe disease in people under 12 as well, including cases of mortality, many of which have been reported from India and other places. So the answer is, again, think of, there is a free rider problem, but to me of even greater concern is that we will not have the trial for children under 12. I have a child under 12,
Yes.
completed for a while. And the only way to protect those kids who are now going to start school in the fall is to reach 70, 80, 90% vaccination among adults, such that in the manner that we saw in Israel, we can protect the people who really need to be protected, which are the children.
So do you think that we're going to be able to reach herd immunity in this country?
I don't know, Wafaa, what you think.
I mean, I think we're going to do it in some parts of the country. I think it's not. I mean, the United States is such a diverse country. So I think we probably will reach it in some parts of the country, like in New York State. I think so. I think New York City, we're going to keep at it, and I think we will get to it. But I think it's not going to be universally across the country. I think that's going to be challenging. I think a combination of the vaccine protection as well as the lesser but some protection amongst people who've been previously infected will get us to where we're going to get to in places like New York City, New York State. I think in Washington State and I think Vermont is doing well, and California. So in some states, but in other, we're going to have parts of the country that are going to remain quite vulnerable to these surges in the future if there isn't a higher uptake of vaccination.
There are parts of the country where the numbers are around 20%.
Right.
And of course, so Tennessee is one of them, if I remember correctly.
Yes.
And so those parts are completely exposed. And we live in a highly globalized world. People are traveling in and out. People are traveling in and out of states. And eventually you can't close the world down. So as Wafaa said, COVID anywhere is COVID everywhere. And unfortunately, it's now going to be Delta COVID anywhere is Delta COVID everywhere,
Right.
which is the most worrisome thing of all. And 20% is just not acceptable. I think, we've been trying. I think a combination of things will help. I call them, we can think of them as carrots and sticks, really. We've done the carrot for a while, and we continue to do that. What we haven't done very effectively, carrot-wise, in terms of offering people incentives, is we haven't done a great job in reaching community groups that are especially resistant. And we have to convince those community groups, and the way to do that is, really what I call, boot and shoe epidemiology, which is, find out exactly where the pockets are, find out who's trusted in those pockets, and then approach those people to become ministers, as you will, of bringing more people to vaccination. So that would be carrot 2. Carrot 1 was the wide availability, the large superpods. We ran a superpod in Los Angeles for a while. We've closed it down now. By we, I mean it was a consortium of people. And then finally comes the stick, which no one wants to use. It's a very political idea. But the stick is that, people are very reluctant to get vaccine mandates. They're very reluctant to get vaccine passports. But the important thing, and Wafaa already identified this, the important thing is, if a private employer is perfectly legally sound for a private employer to demand their employees to be vaccinated, barring religious and medical exceptions. And these cases about these have actually climbed the courts in the United States. And time again, when they've climbed the courts, and the courts have been different, they have been conservative courts, they've been more liberal courts, but time and time again, the precedent has been the courts have said that a private employer is in their perfect right to legally demand that their employees be vaccinated, barring those exceptions. So that is the stick approach, which is to say, you can work from home if you'd like,
Right.
But if you want to come to the office and work from the office, then you have to be vaccinated. And if a lawsuit of that nature were to climb up, which I'm pretty confident that somewhere that it's brewing. If that lawsuit were to climb up, it will probably be struck down in the direction of the employer and not the employee. So the stick is, it's very politically charged. No one wants to do it, but the stick is that once the carrots stop working, we need to get people to get vaccinated based on making mandates of various sorts.
Well, I know some of the airlines, I believe the long haul flights, Qantas, perhaps Emirates are requiring vaccinations. I know there are pre-testing requirements, but a lot of them don't make any sense because they're so far in advance. So what do you think, let's just take the United States, or we could even go smaller and take New York. What do you think the fall and the winter are going to look like?
I can start, and I think I think if we stay in the direction we're going now, I think in places like New York City, New York State, and so on, I anticipate that we'll be doing well. Because I think, again, we're getting more and more vaccinated individuals, and all the evidence thus far tells us that that the vaccines we're fortunate to have, are really good, and particularly in preventing severe illness and more hospitalizations and deaths. And that's what you really care about. I think vaccines, when you think about the influenza vaccine, or the pneumococcal vaccine, the pneumonia vaccine, those were developed to prevent severe illness. They were not developed to prevent infection. Okay, so keep that in mind. So I think a lot of the vaccines are developed to protect from severe complications and not really from infection overall, particularly these adult vaccines. So I think that will be, even if people get infected, a small number get infected, the good news is they won't get very sick and they won't need to be hospitalized, and their lives will be preserved. And that's really important. And that's very important to keep in mind, is as we get to a more vaccinated population, it's going to become more important than ever to look at the severe cases and hospitalizations and deaths and so on, rather than the numbers of cases, because we'll potentially have these very mild or asymptomatic infections, and it's not going to really matter very much so long as people are not getting very sick from them and we have a vaccinated population. So I think our thinking is going to have to change from this idea that there's going to be a day when we're going to eradicate this virus, eliminate this virus, it's going to go away, to more that this is something it's like we're going to tolerate, and we're going to have protective vaccines that protect people from getting very sick from this new virus.
We'll be able to manage it, if you will, and we won't be looking at a horrendous fall and winter, and potentially being able to even go to theater again. And
I think again, if we move in, if we keep in that direction, and there will be some people who get infected, but fortunately they're not going to get sick. And then, as Sid was saying, it's quite likely that it's going to be like influenza, right? Every year there's a new influenza vaccine, right? And it's developed based on the circulating flu viruses, right, around the world. And every year there's a new one that's developed, and everybody gets a shot. We all get a shot in early fall. And it's likely going to be something similar for COVID-19, that there will be potentially a new vaccine developed, and that will be based on the prevailing strains or variants that are circulating around the world. And then people would get vaccinated, once a year, potentially once a year, with this new vaccine. So it might be, we might eventually be in a very similar situation to how we deal with seasonal flu now.
And what do you think worldwide we'll be looking at in the fall and winter, or perhaps take it a different way? When do you think that India and surrounding countries and Africa will be able to get the supply and the distribution they need?
It's a big question, and for a while, as you know, so in India, part of the problem was that it was a self-fulfilling fire, because India not only was severely affected and continues to be severely affected by 1617 in particular, but also India is one of the world's largest makers of vaccines.
Right.
And so when you have both those things come together, that creates a double disaster, because you have the fire and also no fire extinguisher. And that is what actually happened. We were lucky through a consortium that worked extraordinarily hard. We were able to get for a while, the problem was the raw materials used to make the AstraZeneca vaccine are sourced from around the world. And a substantial amount is sourced from the United States. This includes things that you wouldn't even imagine, plastics, serum, stuff like that. And for a while, there was a ban on the export of these products to any country. And ultimately, we were able to lift that. Tony Blinken was involved, the national secretaries were involved. So vaccine production has now resumed, the AstraZeneca vaccine production has now resumed in India. But the problem now still is that given the size of the population and the terrifying wave that spread through India, the government has decided not to release AstraZeneca vaccines outside the use of India, even if they are, even if they're being produced. They've decided that the first priority is to vaccinate Indians. So there is a global shortage of vaccine supply. You heard that President Biden today released 500 million doses, which I commend him for, but I also have to be circumspect and remind us and ourselves that 500 million is a very, 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 very small number. It sounds like a big number, and it's a good thing to do. It's better than zero, but it's a small number. My suspicion is that we aren't, on a worldwide level, we aren't out of trouble for another, I would suspect, 2 years, 1 to 2 years at least.
At minimum, yeah.
At minimum. And we will start getting the vaccines by that time. In places like Delhi and Mumbai, it's really burnt out or burning out, not because of any other reason, but because people who are vulnerable and sick are dead or dying, and it's a terrible consequence. But that's but I suspect, my suspicion is that it's going to be a divided world, a have and have not world, as Wafaa was saying, and people will not be. We won't be out of this for another 2 years at minimum.
I think there are, just to build quickly on what Sid said, I mean, I think donation of doses is really good. And I always remind people, divided by 2. So 500 million doses means that 250 million people get vaccinated, because these vaccines require, the ones he was talking about require 2 doses. So always kind of keep that in mind. But I think there's in addition to donation of doses, buying doses and donating them, that's really good. But I do think another area that we need to be pushing for is technology transfer, because there are places like India is a perfect example that have the knowledge and the capacity and the skills to produce vaccines. There are other parts, Brazil is another country. There's also South Africa, Egypt. There are countries that are really very good at pharmaceutical and vaccine producers. And I think that, again, if there's technology transfer and it's done rapidly, that will also help, as well as the whole issue around the easing of some of the patent restrictions, which is going to take time.
Let's talk about that. I think it's a very important topic, and it is a place where people who are not in epidemiology and not doctors per se, but really are in politics, can play a major role, because the capacity to overlook or override patent and TRIPS agreements on a single case basis when there's a worldwide emergency, without this affecting hundreds of other medicines, but being specific only for vaccines, is something that can be negotiated. It could be but it requires constant pressure. And potentially a reward system, reward
incentives.
Yeah, so to provide incentives, at a foundation level or at various levels, provide a $1 billion, $2 billion incentive to the company, saying, "Great, you've done a wonderful job, but we now need to move the vaccine production to places. Otherwise, as I said, this will continue. It also harms us." So it's an international biothreat, and people who work on these kinds of questions, international biothreat questions, I think should be very actively negotiating a one-time or technology transfer apparatuses that are appropriately incentivized, but are also timely. Doing this, 2 years from now is too late. We need to do it now. So if you're in that arena, that's, your work is cut out for you.
One of there are 2 things I wanted to get to before we have to stop. One is to return to the children. Pfizer announced a very aggressive schedule of having children, I forget if it was 5 and up or 6 and up, vaccinated in September, and then as young as 6 months in November. And I wanted to know your thoughts on that, because now whether you're in a grocery store or you're walking down the street or you're on an airplane, with certainly an infant that can't be masked, these children are exposed. Do you think that it will be enough time to kind of right size and trial these vaccines for these very young children?
As I said, in the United States, it's becoming difficult because the caseloads are going down so dramatically. I mean, vaccination is I call it a Goldilocks point. You have to be at the exact right place in terms of caseloads and the rise of caseloads in order to run a trial in good time. If there are too few, it takes too long. If there are too many, it's often too late. And so in India, what happened is that they were too many and it was too late. Now we're catching up to some extent. In the United States, the problem is that there are unfortunately too few, as far as we can tell. Again, any second there might be a surge in Tennessee. There might be. I'm I would love it if I could get my 12-year-old vaccinated, or under 12-year-old vaccinated, excuse me. But I suspect that that trial will have to move outside the United States for it to be successful. And the problem, as you know, is that once a major pharmaceutical company moves a trial outside the United States, there are all sorts of resistances that go up for historical reasons and other reasons. And so this is going to be I think a real challenge.
A big challenge. And lastly, there was a lot of focus on testing and rapid testing and having a 5-cent disposable test that we could all do that was reliable. That so far is not materialized, and we still are doing. And I think for anybody who's read a recent book on the pandemic, we've still done the most minimum amount of genetic analysis of these of people who are sick and these variants. Is it over? We don't care about testing anymore. We've given up on sequencing. What do you think?
I hope not. But I think as Wafaa said, this is going to be in human. It's like influenza, right? Mm-hmm. Influenza is a good example. We continue to monitor around the world all the circulating strains. We sequence them. We make the vaccines based on the circulating sequences. And although influenza is, we test less, we will certainly. But we're in this for the long haul. So as I said, the only way to shorten it right now is to get vaccinated. And in places where vaccines are not available, the only way is to continue distancing, masking, and isolation, and testing where testing is available. There's nothing else to do in those places until the vaccines arrive.
Wafaa, any closing thoughts?
No, I think we're actually more than ever, we're going to need to continue to do sequencing. And I think that's why I don't think we should slow that down, because we need to identify variants as they arise so we can use them for the next vaccine and so on. And testing continues to be an important tool. I think, of course, as more and more people, it depends now who you want to be vaccinated. I think for unvaccinated individuals, certainly they will need to have more regular testing than vaccinated individuals, but there will remain an important role for testing. And obviously for anyone with symptoms that suggest COVID-19, absolutely testing is required.
Sid, any final thoughts on the pandemic?
No, I think we've forgotten how important testing can be. And that is one way that schools are now opening, because the kids are not eligible for the vaccines. So one way, it is a system that is bound to have, unlike vaccines, there's bound to be holes in it, because you test one day and maybe in the interim time that you get your next test, you're already infected and you're spreading. So that would be something that we should and will continue to do.
Well, I want to thank you both so much for spending this time. I know how important your time is, and really helping to shed light as we finally come out and contextualize where we are on the global stage. And I think the point made earlier that we are one person getting off one plane away from the variants being here. And so we really must be good global citizens, if from a moral perspective, but also from enlightened self-interest.
Thank you very much.
Well, thank you. Have a wonderful summer. Stay healthy, and we'll reconvene.
Thank you. Thank you.
Thank you so much.